Bienvenidos al quinto Congreso Mundial de Sexología Médica. Este congreso es patrocinado por
Good morning, good afternoon and good evening, and welcome. Over the next 30 minutes I will discuss the role of testosterone in the maintenance of sexual and reproductive health, the deficiency of testosterone, commonly called hypogonadism, its diagnosis, its management, and the relationship between hypogonadism, cardiovascular disease, and prostate cancer. Now, testosterone is an anabolic steroid with the typical 4-ring steroid configuration. It is the primary sex hormone in men. It is produced by the Leydig cells of the testis and to a much, much lesser extent the adrenal cortex. Its synthesis is regulated in a negative feedback control system by the hypothalamic pituitary gonadal axis and involves pulsatile secretion of gonadotrophin releasing hormone, GnRH, by the hypothalamus, and pulsatile secretion of both LH and FSH by the anterior pituitary. The mechanism of androgen action in target tissues is well understood. Testosterone enters the target cell, is converted by an enzyme called 5-alpha reductase to dihydrotestosterone, or DHT, and it's DHT and testosterone that bind to androgen receptor proteins within the cell nucleus, and these hormone receptor complexes bind to specific DNA sequences and regulate messenger mRNA transcription and synthesis of the specific proteins required for sexual differentiation, the induction of puberty, and the development of the external features of the male phenotype. The testis of a young healthy man secretes 5 to 6 milligrams of testosterone into the plasma each day, and almost all testosterone is transported in plasma bound to protein, largely to albumin and to a specific transport protein, sex hormone binding globulin, or SHBG. Approximately 1 to 2% of testosterone is unbound in the plasma and circulates as free testosterone, and the bound and unbound fractions are in dynamic equilibrium. Testosterone binds strongly to SHBG, but its affinity for albumin is relatively weak. As a result, testosterone readily dissociates from albumin, adding to the fraction of circulating testosterone which is available for entry into the tissues. So, what constitutes a definition of testosterone deficiency? Well, the presence of multiple signs and symptoms of testosterone deficiency that persist over time, and a biochemical measure of testosterone that is either low or borderline below the lower limit of normal accepted for the laboratory performing the assay. There are 3 main types of testosterone deficiency: primary hypogonadism, or testicular failure, where LH is raised; secondary hypogonadism, due to hypothalamic or pituitary dysfunction, where LH is either low or normal low; and finally, compensated hypogonadism, where early testicular failure is compensated for by a rise in pituitary LH secretion, which maintains normal or low normal levels of testosterone. And the table on the slide details what occurs in each of these conditions and what the biochemical findings are on laboratory testing. The European Male Aging Study provides observational data which identifies the cutoff point for the diagnosis of testosterone deficiency. Normal testicular function, or eugonadism, occurs when the total testosterone is in excess of 10.4 nanomoles per litre and the LH is less than 9.4. In primary hypogonadism, the total testosterone is less than 10.4 with a high LH in excess of 9.4. Whereas in secondary hypogonadism, due to hypothalamic or pituitary failure, the total testosterone is reduced at less than 9.4 with an LH which is either low or low normal. In compensated primary hypogonadism, total T is normal or low normal with a high LH reflecting a maximal or close to maximal LH secretion and a real prospect of eventual fall in testosterone. Testosterone production declines as men age. From the age of 45 to 50, testosterone production reduces by 1 to 2% per year. And in parallel with this decline, production of SHPG, sex hormone binding globulin, increases, resulting in a reduction in the level of biochemically active free testosterone. In addition, the pulsatility and the circadian rhythm of secretion of hypothalamic GnRH and pituitary LH flattens, as the red line on the graph shows, leading to steady state low levels of testosterone throughout the entire 24 hours. This age-related decline in testosterone was demonstrated in the Massachusetts male aging study, where the changes in testosterone levels were measured over 3 separate decades and demonstrated, as the graph on the right shows, a substantial decrease in testosterone in American men as they age. In a post hoc analysis of this data, the increasing incidence of hypogonadism as men age was demonstrated, shown in slide A, with an incidence of 18.6% amongst 70-year-old men in slide B, and an overall crude prevalence of symptomatic testosterone deficiency of 5.6%. So, what is the physiological role of testosterone in men? Well, testosterone maintains reproductive tissue and by doing so stimulates spermatogenesis and maintains sexual function. Testosterone has an important role in maintaining bone and muscle mass. It produces male secondary sex characteristics such as axillary and body hair growth and distribution, and it stimulates production of red blood cells or erythrocytosis. The symptoms and signs of low testosterone include a number of sexual symptoms such as hypoactive or reduced sexual desire, erectile and ejaculatory dysfunction, as well as progressive loss of muscle mass and the development of osteopenia or frank osteoporosis. In addition, men with a testosterone deficiency may report a spectrum of vague symptoms, including lethargy, depression, and a reduction in cognitive abilities. Men of reproductive age may be infertile or subfertile due to either oligo or azoospermia, and older men may progressively lose male secondary sex characteristics with testicular atrophy, loss of muscle mass, and loss of body hair. When we examine these men, we need to initially look at their stature. There is often a degree of visceral or central obesity as part of a metabolic syndrome. We need to examine for the presence of male secondary sex characteristics, the amount and distribution of body hair, the possible presence of gynecomastia. We need to do a focused examination of their external genitals, recognise that testicular atrophy may eventually occur, and finally we need to regard this as an ideal opportunity for screening for prostate cancer with a digital rectal examination and a PSA. There is a close link between testosterone and erectile function. ED tends to only occur if testosterone drops below 5 to 6 nanomoles per litre, and there is ample basic science data to support the fact that testosterone regulates nerve function and structure, regulates the expression and the activity of both nitric oxide synthase and the PDE5 enzyme, and has an important role in cellular differentiation and in cellular growth. Testosterone deficiency is linked to a number of diseases and is associated with an increased risk of mortality. These conditions include endothelial dysfunction and the subsequent development of atherosclerosis, of hypertension, insulin resistance and diabetes, and of course the metabolic syndrome. The data we have suggests that there is a strong link between hypogonadism and insulin resistance. The Australian Health in Men study demonstrates that men with a total testosterone of less than 8 nanomoles per litre have an increased risk of type 2 diabetes in the highest quintile with an odds ratio for insulin resistance of 1.67. Furthermore, and perhaps of even more concern, is the observation that the same study demonstrated that men with normal low testosterone in the range of 8 to 15 nanomoles per litre also have an increased risk of odds ratio of insulin resistance with an odds ratio of 1.29. Bob Clanner, in a comprehensive review of the literature, looked at the relationship between testosterone and cardiovascular disease and found that there was an association between low testosterone and both the prevalence and severity of coronary artery disease, the thickness of carotid artery intima and mortality, and that testosterone replacement reduced the elevated lipid levels that characterise these conditions and reduced the inflammatory markers seen with cardiovascular disease. The Shores male veteran study of 858 men demonstrated that low testosterone is associated with increased mortality. Mortality over 5 years was 20.1% for men with normal testosterone levels, but significantly higher at 34.9% for hypogonadal men. The odds ratio for mortality in hypogonadal men is 1.88, and the Kaplan-Meier curves on the right-hand side of the screen demonstrate the difference, the clear difference between these three populations of men. Much has been published in the literature over the past 5 years on the relationship between testosterone replacement and cardiovascular disease. So we must ask and answer the question, does testosterone replacement therapy reduce cardiovascular risk factors? Well, I think the answer is, as you'll see in the next series of slides, is a clear yes. In a second study by Shores, which again looked at the relationship between testosterone deficiency, testosterone replacement and mortality, the mortality at 3 years for untreated hypogonadism was 20.7% and was 50% less at 10.3% for men who received testosterone replacement therapy. Other studies have confirmed this finding. This particular study, looking at men with type 2 diabetes, demonstrated that testosterone replacement therapy reduced mortality at 5.8 years by 50%, 20% versus 8.6%, which in fact approximates the mortality of normal controls. The differences between low treated testosterone, normal testosterone, and low untreated testosterone are nicely demonstrated in the Kaplan-Meier curve on the right-hand side of the slide, and the mortality hazard ratio for untreated low testosterone was high at 2.3. And most recently, the benefits of long-term testosterone replacement by a reduction of cardiovascular risk and mortality was demonstrated in this large registry study from Tracy's group, which demonstrated that there was an estimated reduction in mortality for testosterone-treated patients as opposed to the untreated controls of somewhere between 66 and 92%. There were 26 non-fatal myocardial infarctions and 30 non-fatal strokes in the untreated control group versus none in the testosterone replacement group. And this, I believe, represents convincing data that testosterone replacement therapy in hypogonadal men is associated with a significant reduction in mortality. So why does this benefit occur? Well, men receiving testosterone, the green bars, compared to untreated controls, the red bars, had lower hemoglobin A1Cs, lower cholesterol levels, lower systolic and diastolic blood pressures. Furthermore, testosterone replacement appears to improve overall arterial health. Antonio Aversa evaluated the effect of testosterone replacement using a long-acting testosterone called Nebido on carotid wall thickness and demonstrated a significant reduction in men receiving testosterone, the green squares, and in the graph on the right, an inverse relationship between total testosterone levels and wall thickness. Okay, so how do we diagnose testosterone deficiency? Well, to document that a patient has a low testosterone level, we must measure a morning total testosterone level. In older and in obese patients, it may be more helpful to do a free testosterone level as well, because SHBG levels are decreased in obesity and increased in older individuals. If the level is low, you should always confirm the initial low value with a second specimen collected between 7 and 10 a.m. A total testosterone of less than 10.4 nanomoles per litre suggests hypogonadism. Again, emphasising how important it is to screen for prostate adenocarcinoma in this population, always do a PSA and a digital rectal examination. So, is there a place for screening for testosterone deficiency in older men? In men who are deemed to be at an increased risk, it's probably reasonable to screen for testosterone deficiency with a morning total testosterone. And this at-risk population will include men who present with ED or men who have normal erectile function but have a history of type 2 diabetes, of metabolic syndrome, or of chronic renal failure. We may need, depending on that initial total testosterone, to do further biochemical evaluation. Measurement of pituitary gonadotrophins, LH and FSH, is important, as is the measurement of prolactin. Free testosterone is often measured and is useful, particularly in older men. The gold standard assay is equilibrium dialysis, but this is difficult, time-consuming, and requires extensive validation. So most laboratories nowadays will calculate free testosterone. You can, in fact, do this yourself using a number of websites that will calculate free testosterone levels. Indirect measures, such as the free androgen index, correspond poorly with direct measurements and lack the empirical validation required as a reliable diagnostic test. The level of sex hormone binding globulin, SHBG, should be measured and will increase, as already mentioned, as men age and in men with liver failure, resulting in low levels of unbound physiologically active free testosterone. In addition, we should look at estradiol, at TSH, and perform any other tests which may be determined by the patient's history or the findings on physical examination. And these may include a pituitary MRI for a patient with hyperalactolemia or a patient with secondary hypogonadism. In the occasional patient where we suspect Klinefelter syndrome, it may be appropriate to karyotype the patient, and it may be reasonable in some patients, particularly those who have liver failure or are suspected of having hemochromatosis, to do iron studies with serum ferritin levels and iron saturation levels. Okay, so let's move on to the treatment of testosterone deficiency. There are a number of different routes of administration of testosterone, and these include topical, intramuscular injections using either short-acting or long-acting testosterone, or oral testosterone undecuinate. And each of these has its advantages and its disadvantages. Nowadays, one of the most popular initial approaches is topical transdermal testosterone using a hydroalcoholic gel such as Testogel, Androgel or Axiron, which are applied in the morning, or an impregnated testosterone adhesive patch, Androderm or Testoderm, which is used at night. The use of patches is limited to a degree by skin sensitivity to the adhesive gum within the patch. There may be contact transfers of gels to a partner, and these treatments, while simple to use, do require significant compliance and may represent inadequate testosterone placement in younger men. There is some interest in the application of testosterone cream to the scrotum. The scrotum has a very thin stratum corneum. It has much higher permeability to topical anabolic steroids, 8 times higher in fact, and it minimises the risk of passive transfer to partners. The graph on the right-hand side of the screen shows serum levels of testosterone versus time for transscrotal application of a testosterone cream available in Australia called Androfoot. Oral testosterone, Andriol, comes as an oil-filled capsule which facilitates absorption via intestinal lymphatics and avoids the hepatic and gut wall first pass metabolism. Its use is limited by relatively poor bioavailability as it needs to be administered at least 4 times per day by the presence of GI intolerance and its relatively high cost. It tends to be infrequently used by the physicians who commonly see patients with testosterone deficiency. Parenteral testosterone, these are testosterones which are esterified to fatty acids and are usually formulated in a vegetable oil vehicle. Short-acting testosterone, such as Sustanon or Primatestin Depot, are administered every 12 to 14 days. They are, however, associated with fluctuating circulating testosterone levels, often with initial supraphysiological levels and low trough levels immediately before the next injection, producing a roller coaster effect upon mood. Long-acting testosterone, such as Reandron or Libido, are administered every 2 to 3 months, and all parenteral testosterones are associated with an increased risk of polycythemia due to increased erythrocytosis. Testosterone implants have been used for many years. They contain a crystalline testosterone and are inserted subcutaneously under a local anaesthetic and offer hypogonadal men testosterone replacement for approximately 6 months, as the dose pharmacokinetic curve on the screen shows. Now, the literature contains a number of published guidelines, and on the screen you have the clinical practice guidelines of the Endocrine Society, which we won't bother to go into in any detail. However, a snapshot of these guidelines recommends that testosterone be replaced to mid-range levels, that patients be monitored after commencing testosterone replacement therapy by checking their testosterone level periodically to assess both treatment efficacy and patient compliance. Monitoring requires serial clinical observation. The restoration of sexual function will occur at a relatively low change in testosterone and is not a sufficient indicator to indicate adequate replacement. These patients need to have a limited number of testosterone assays, usually one every 6 to 12 months, and should also have a hematocrit to look at red cell mass, a PSA and an estradiol level. Patients should initially have a bone density study, and depending on the findings of that study, may require treatment and follow-up bone density studies. Low testosterone levels are associated with an increased risk of osteoporosis and fracture, and testosterone replacement therapy in hypogonadal older men markedly increases bone mineral density in both the spine and the hip over a 3-year period. When should we assess adequacy of replacement? In patients on a topical testosterone, we should assay their morning testosterone, their total testosterone after 3 to 4 weeks, and at least 2 to 3 weeks after a dose. In patients on a short-acting testosterone, we should assay their testosterone level mid-cycle after 3 to 4 weeks injections, or 3 to 4 injections. And in patients on a long-acting testosterone, such as Reandron or Libido, we should do a trough testosterone level 1 to 2 weeks before the 4th injection. Random testosterone levels in these patients are of little use and are difficult to interpret. In hypergonadotrophic hypogonadism, primary testicular failure, suppression of the initially elevated LH levels into the eugonadal range is expected. In fact, most of these men have almost unrecordable levels of LH. Failure for that initial elevated LH to reduce after 3 to 6 months of treatment indicates either inadequate dosage or poor compliance. On the other hand, in men who have secondary hypogonadism, hypogonadotrophic hypogonadism due to hypothalamic or testicular failure, blood gonadotropin levels are uninterpretable. Estradiol is synthesized in men from metabolism of testosterone by the aromatase enzyme found in fat. Administration of exogenous testosterone may increase estradiol levels, resulting in suppression of LH secretion and an increased hepatic synthesis of SHBG, which reduces free testosterone levels. Of particular interest is the observation that high estradiol levels have been noted in men with ED, and that they may be linked to corporal venous leakage, supporting the notion that estradiol levels can adversely affect penile smooth muscle function. What constitutes an inadequate clinical response to androgen replacement therapy? Well, clearly inadequate maintenance of testosterone levels with or without persistently elevated LH levels indicates under-replacement. These men may occasionally require an increased dose of topical testosterone, but more often are better managed with parenteral testosterone. Normally, we would start a short-acting testosterone at intervals of 2 weeks, but some patients may require progressive reduction down to a 10-day frequency. And similarly, with a long-acting testosterone such as Nebido or Reandron, the initial frequency of 3 months may be reduced from 3 to 10 weeks or even 8 weeks. The failure to achieve benefit from replacement raises doubt about the initial diagnosis of testosterone deficiency, as does the presence of recalcitrant symptoms which fail to improve once testosterone reaches within the normal range. Side effects. Adverse effects of testosterone replacement therapy are relatively uncommon and include acne, excessive hair growth, weight gain, gynecomastia, and male pattern hair loss. Perhaps the most insidious side effect, which is most often seen with parenteral testosterone, is polycythemia, an increase in red cell mass. This is particularly of concern in older men and may, if unrecognised and not treated, result in a higher risk of cerebrovascular accident. There are a range of treatment-specific adverse effects, including discomfort from intramuscular injections, GI upset with oral testosterone undecanoate, and offensive body odour with some topical testosterones. Does testosterone replacement therapy increase the risk of prostate cancer? Is this fact or is this fiction? Well, the relationship between prostate size, PSA and testosterone has long been recognised and is clearly demonstrated in this 1994 study, which demonstrates that after treatment with testosterone, PSA and prostate volume increase, but only rise to the level of age-matched controls. In addition, testosterone replacement therapy had no effect on the presence of lower urinary tract symptoms or on uroflow. In this slightly more recent study, where men were treated with either placebo or weekly testosterone levels for 10 weeks, despite the achievement of supraphysiological levels of testosterone, the blue lines, the PSA level, the red line, did not significantly change. The reality is that men with low testosterone are most at risk of developing prostate adenocarcinoma, and as such, the initial dogma that testosterone replacement therapy either promotes or feeds prostate cancer appears to be incorrect. In fact, a review of the literature demonstrates that it is low testosterone that is the risk factor for prostate cancer. Hypogonadal men tend to have higher pathological stage prostate cancer, higher Gleason biopsy scores. They're more likely to have positive surgical margins, and unselected hypogonadal men are more likely to have unrecognised occult cancer, with an incidence in Abraham Morgan Taylor's 1996 study of 14.7%. These and other data were reviewed in Abraham's Morgan Taylor's landmark publication in 2009, which described the prostate saturation model. The traditional androgen-dependent view of prostate assumed that prostate growth would increase as serum testosterone concentrations increased, as suggested by curve A and B on the left-hand graph. However, Morgan Taylor proposed that prostate growth and its surrogate PSA, while sensitive to changes in serum testosterone at low extreme concentrations of testosterone, eventually reached a plateau as serum testosterone increases, curve C. And once this plateau is reached, presumably due to maximum binding of testosterone to the androgen receptor within the prostate, the system appears saturated and no further prostate growth occurs, even with large increases in testosterone levels, as indicated by the graph on the right-hand side of the slide, the red curve. And a number of authors have confirmed this hypothesis in a clinical setting. This is a study from Mo Kira from Baylor, 57 hypogonadal men who had a radical prostatectomy and were treated with testosterone replacement therapy for a mean follow-up of 3 years. Their testosterone predictably increased from a baseline 255 nanogram per deciliter to 459 with no increase in PSA. And the authors correctly concluded that whilst testosterone is effective in improving testosterone levels, it does not cause any increase in PSA. And consistent with that, none of the 57 patients in this study had any biochemical recurrence of prostate cancer. There are, of course, some precautions in the use of testosterone replacement therapy, particularly in older men who may not cope well with unfamiliar increases in libido. We should be cautious with the use of intramuscular replacement in patients with bleeding disorders. Very occasionally, we see testosterone-sensitive epilepsy, migraine, sleep apnea, and certainly some concern should be used in men with pre-existing polycythemia, in men with severe, difficult to control hypertension, or poorly controlled cardiac or renal failure due to the risk of fluid overload from sodium and fluid retention. For general practitioners, who should they refer their patients to when they feel less comfortable managing these patients themselves? Well, if a patient has sexual dysfunction, refer them to a sexual health physician or an interested urologist. Clearly, a urologist is the best person if PSA is increased or if digital rectal examination is abnormal. If a patient has raised prolactin or an abnormal pituitary MRI, send them off to an interested endocrinologist. Psychologists have a key role as part of an integrated treatment program for patients with hypoactive sexual desire or relationship difficulties. Refer to a cardiologist for patients who we regard as having a higher risk of cardiovascular disease, to have an exercise ECG and perhaps a CT calcium score performed. And if pregnancy is required and the patient is either sub-fertile or infertile, refer them to an andrologist. There are a number of different algorithms, and this is quite a nice one from Nish Lag, which looks at the way patients are managed based on their investigations. So, in conclusion, testosterone deficiency symptoms are common in older men. Testosterone deficiency is often underdiagnosed, and many men as a result are inadvertently denied treatment. It may be associated with an increased risk of coronary artery disease, of diabetes, of metabolic syndrome, and increased mortality. Replacement therapy appears safe in men with treated prostate cancer and does not appear with the evidence that we currently have to increase the risk of cardiovascular disease or of any major cardiac events. I'd like to thank you for your interest. I hope you enjoyed this video presentation and wish you all the best.
Este congreso es patrocinado por